Welcome back to the Deep Dive. Our mission here is to act as your expert navigators, taking these, well, incredibly dense surgical textbooks and really transforming them into knowledge that's both instantly graspable and hopefully sticky in your memory.
And today we are diving into an absolute classic. We're looking at the 28th edition of Baily and Loves, and specifically, we're dissecting Chapter 41, the foot and ankle.
Which is a chapter that I think for many people can feel like a bit of a labyrinth. You know, all these tiny bones, complex pathologies. Our goal is to give you that context, to clarify the why behind the surgical choices.
Exactly. And to give you those crucial memory anchors, just a crucial disclosure right up top, this is our interpretation. It's a simplification. It is absolutely not a substitute for reading the full textbook.
Right. Think of this as your ready reckoner, maybe a revision tool, something you listen to before you read to get your bearings, or after to make it all stick.
Mm-hmm. We're going to use metaphors, clinical context, everything we can to make sure these concepts are retained.
Okay, let's jump straight in. Section 1, the foundation. The architect's blueprint.
Right, the blueprint.
If you just look at a diagram of the foot, it just seems impossibly complex.
Yeah.
But it's this brilliant piece of engineering, really.
It is. It's designed to transform from, a flexible shock absorber to a rigid liver. And the numbers really tell the story. The source anchors us right away. We're dealing with a framework of 26 major bones.
26. 7 tarsals, 5 metatarsals, 14 phalanges.
Exactly. And that doesn't even include the 2 sesamoids under the big toe, which, as we'll see, are clinically, very important. Or the variants, like the biphalangeal 5th toe.
So the skeleton is the hardware. But the movement, the software, that's where it gets interesting. The ankle joint is often just called a simple hinge.
Yeah, and that's a huge oversimplification. The book makes it really clear that the mechanics are far more complex. It actually describes the ankle joint as a truncated section of a cone.
A truncated cone. Okay, that's not just jargon, right?
Yeah.
That is a real-world consequence for how we move.
It absolutely does. It dictates the entire functional movement of the lower limb. Because the talus is wider at the front than at the back, the movement isn't just up and down. It's not linear.
So what does that mean in practice? When I lift my foot up?
When you dorsiflex, that wider anterior part of the talus wedges into the mortise, and it forces the fibula to externally rotate just a little bit at the syndesmosis.
Ah, I see. And when you point your toes down?
The opposite. Plantar flexion engages the narrower posterior part, which allows for a bit of internal rotation.
So it's not a door hinge, it's more like a finely tuned rotating mechanism.
Precisely. And the stability of that whole system, the mortise, relies not just on the bony fit, but crucially on the ligaments.
The ropes holding it all together?
The medial deltoid ligament, the lateral ligaments, and especially the inferior tibiofibular ligaments, the syndesmosis. If that's injured, you lose control of that rotation. You get an unstable, widened mortise.
Which is your classic high ankle sprain.
That's it. Okay, moving back a bit to the hindfoot, we have what the outline calls the triple joint complex.
The inversion-eversion engine.
I like that. It's the subtalar joint, the talonavicular, and the calcanea cuboid. And the key thing to remember here, the anchor, is their codependence. They do not operate independently.
Right. So if one joint is stiff or fused, it affects the others.
It has to. Their job is to manage inversion and eversion, turning your foot in and out. That's what lets you walk on uneven ground. When you invert your foot, the whole complex locks up and becomes rigid.
And when you avert?
It unlocks, becomes pliable, and conforms to the ground. It's this incredible dynamic stabilization system.
Okay, let's move forward into the midfoot, the tarsometatarsal, or TMT region. And this is where we find that critical structural component, the TMT keystone.
The second TMT joint, it's recessed, it's tucked in between the first and third metatarsals, and that positioning provides massive stability. It's just like the keystone in a Roman arch.
And when that keystone fails, you get a Lisfranc injury.
Exactly. Named after Jacques Lisfranc, surgeon in Napoleon's army. It's a disruption of that keystone, and it leads directly to a collapse of the transverse arch, an acquired flat foot.
And they can be really subtle on an X-ray, can't they?
Devastatingly so. You can miss it, but functionally it's a catastrophe if you don't fix it meticulously.
Right. Now, all this movement needs a lot of muscular control. The source flags the 4 compartments of the lower leg as a favorite examination topic.
And for good reason. Compartment syndrome is a surgical emergency. So quickly, you have the superficial posterior, your big calf muscles, the propulsive engine.
Gastroc and soleus.
Then the deep posterior. This is your dynamic arch support. Tibialis posterior, FDL, FHL.
You've got the lateral compartment.
The peroné. for eversion and stability. And finally, the anterior compartment for dorsiflexion. And it's that anterior and the deep posterior compartments that are really tight and most susceptible to compartment syndrome.
A real emergency. Okay, the final piece of this blueprint, the windlass mechanism.
This is what truly makes walking efficient. The plantar fascia running from the heel to the base of the toes.
And the anchor here is hoisting a sail, right? Or cranking a winch.
That's a great way to think about it. As your heel lifts off the ground for toe off, your big toe is forced upwards into dorsiflexion.
Okay.
That upward movement acts like the winch handle. It pulls the plantar fascia taut, and that tightening action draws the heel and forefoot closer together, which dramatically accentuates the arch.
And that's what turns the foot into that rigid lever we were talking about.
That's the whole mechanism. Without it, your push-off is inefficient, weak, a floppy foot.
That's a fantastic overview of the architecture. So let's pause for a moment. Pause and reflect. If you had to explain the unique motion of the ankle joint and the primary function of the triple joint complex to a colleague, could you do it? Specifically, can you describe why movement isn't purely linear, referencing the truncated cone? If you need to nail down that cone versus codependent inversion engine idea, rewind and listen to that section again. Understanding this architecture is the key to understanding the pathology we are about to cover.
Yeah, it's a good check-in. So the key takeaways, S1 for this section, are we've got 26 bones, ankle rotation accompanies flexion and extension, the triple complex controls inversion, and that brilliant windlass mechanism creates the rigid lever for walking.
Okay, with that foundation in place, let's move on to where things go wrong. Section 2, forefoot fault lines. We'll start with the most common one, hallux valgus, or the big toe rebellion.
Right, hallux valgus. So deviation of the big toe towards the lesser toes. But the key is that it's really a deformity of the first metatarsal head, which deviates medially.
And that medial prominence is what everyone calls a bunion.
Exactly. The bone and the inflamed bursa over it. It's common, often bilateral, and affects women far more than men.
Now, the cause, is it just shoes?
The book is clear that the inherited tendency is the main thing. The predisposition is genetic. But restrictive footwear, narrow, fully enclosed shoes, they absolutely accelerate it and make it symptomatic.
So shoes don't cause it, but they pour gasoline on the fire.
A perfect analogy. But the real danger here, the clinical pearl, is the domino effect.
The knock-on effect.
Yes. As the first metatarsal moves medially and gets elevated, it stops doing its job. It stops bearing its share of the load during push-off.
And that load has to go somewhere.
It goes right next door. You get this massive overload of the second MTP joint.
And that's the critical thing to look for on examination.
Absolutely. The second MTP joint isn't built for that stress. It gets painful, swollen. The plantar plate beneath it can get disrupted or even rupture. Eventually, you see a prominent, painful callus under the second metatarsal head, and the second toe itself can become hammered or even dislocate. A real secondary deformity.
So management is all about correcting that alignment and redistributing the load. Non-operative first, wider shoes.
Pressure relief, yeah. But when we get to surgery, the choice is all about the severity of the deformity. It's a spectrum.
So for a mild deformity.
For a mild deformity, you can do a distal osteotomy, like a chevron. It's a simple V-shaped cut near the metatarsal head that lets you shift it back into place.
But for a moderate to severe problem, you need more power.
You need more leverage, so you have to move further up the bone. For moderate cases, you're looking at shaft osteotomies, like the scarf or the Ledloff.
The scarf osteotomy. The book says it's named after a carpentry joint. Why is that? What's the advantage?
Well, it's a long Z-shaped cut down the shaft of the metatarsal. Because it's so long and interlocking, you get a huge surface area for bone healing, which is great. But crucially, it lets you correct in multiple planes.
Oh, so you can shift it sideways and deal with any elevation.
Exactly. You can shift the head laterally and also derotate it or lower it down to get it back on the ground, bearing weight. It's very stable.
Okay, but what about the most severe cases? The outline mentions a hypermobile or unstable TMT joint.
This is the game changer. If the base of that first metatarsal is unstable and wobbly, doing any kind of correction further down the bone is pointless. The deformity will just come right back.
Because the foundation is unstable.
Precisely. So you have to address the foundation. You have to fuse the first TMT joint. That's the modified Lapidus procedure. You're locking the entire first ray down to prevent recurrence.
But these bigger basal procedures must have their own risks.
They do. They allow for massive correction, but you have to be so careful not to elevate or depress that first ray too much. If you elevate it, you're just recreating the problem you tried to solve. You're transferring all the load to the second MTP joint again.
So they need really robust fixation with plates and screws.
Mm-hmm. And then there's the salvage option for the elderly, low-demand patient.
Keller's excision arthroplasty.
Right, where you just chop off the base of the proximal phalanx. The book is very clear that this defunctions the toe and sesamoids. It's a quick fix for pain, but the toe becomes floppy, weak, not great for function.
Which probably explains why the source is so cautious about patient satisfaction.
The numbers are pretty sobering. 10% report significant reservations, another 20% mild reservations. It's a tough surgery to get perfect, and the risks are real. Recurrence, nerve damage, stiffness, and those transfer lesions we talked about.
Okay, let's move to the opposite problem. Not the rebellious toe, but the hallux rigidus, the rusty hinge.
This is just arthritis of the big toe joint. Painful loss of motion, especially that upward bend, dorsiflexion, and it's caused by osteophytes, bony spurs that form around the joint and block movement.
Often a history of trauma, like an athlete.
Microtrauma, yep, or family history. And if the problem is pain on movement, the non-operative anchor is simple. You stop the movement.
So stiff shoe.
Absolutely. The source says the most effective conservative treatment is a stiff-soled shoe with a deep toe box, or a rocker bottom sole. It basically does the work for the toe, so it doesn't have to bend.
And if that fails, what are the surgical mainstays?
Again, a spectrum. For early or moderate disease, do a chelectomy. You go in and you debride and excise those blocking osteophytes. It's an unblocking procedure.
And for end-stage arthritis?
Fusion, arthrodesis. You eliminate the joint, you eliminate the pain. It's highly effective. And patients can usually still be very active, even play sports. The main downside is it can sometimes cause pain under the fused joint from the sesamoids.
What about joint replacement? Prosthetic arthroplasty.
The source is pretty scathing about it, actually. It highlights the high failure rates, notes that many prostheses have been withdrawn from the market. The long-term data just doesn't show an advantage over a good old-fashioned fusion or chelectomy.
So fusion is still the gold standard?
For reliability, yes.
Okay, couple of smaller issues. Sesamoid problems and Freiberg's disease. Let's start with turf toe.
Turf toe is an acute hyperextension injury. You disrupt the plantar plate under the big toe, often in athletes on artificial turf. Mild cases get better with rest. A complete rupture, though, a grade 4, that often needs surgery.
And Freiberg's.
That's an osteonecrosis, an infarct of the bone, usually of the second metatarsal head. It often settles with rest in adolescence. In adults with a destroyed joint, you might do a reshaping osteotomy, but the book says you should never just excise the whole metatarsal head. That's a functional disaster.
Right. That brings us nicely to our case study. Fictional case study. Morton's neuroma. So a 30-year-old runner comes in. She has this sharp, burning pain between her third and fourth toes. She says it feels like she's walking on a marble, and it's much worse in her narrow running shoes.
Textbook Morton's neuroma. It's not a true tumor. It's a paraneural fibrosis, just compression and irritation of that common digital nerve between the metatarsal heads.
And the treatment?
Non-operative first, always. Wider shoes, unorthotic with a little dome to splay the metatarsals apart, and a steroid injection, usually under ultrasound, can be very effective.
But if that fails, surgery is nerve resection, which means permanent numbness.
Yes, and the patient has to be very clear on that. But the real caution is the complication rate. The book quotes a 5% risk of a permanent bad outcome.
What kind of bad outcome?
A painful stump neuroma or even a complex regional pain syndrome, which is why the source mentions that European trend of just cutting the inner metatarsal ligament to decompress the nerve without actually cutting the nerve out. It's a balance of risks.
Okay, let's pause and synthesize this section on the forefoot. Pause and reflect. Think back to the hallux valgus surgery discussion. If a patient presents with severe hallux valgus and a hypermobile TMT1 joint, that unstable base, why does the preferred surgical strategy shift from a mid-shaft osteotomy, like the scarf, to a fusion procedure, like the lapidus? Consider the mechanical risk of recurrence. If you can't immediately articulate the connection between hypermobility and the need to stabilize the entire first ray, take a moment to review that concept.
Good question. And the key takeaway is S2R. Hallux valgus disastrously shifts the load to the second MTP joint. Hallux rigidus needs a stiff sole to offload that rusty hinge. Your surgical choice for a bunion depends entirely on the severity and, critically, the stability of that first ray. And Morton's neuroma treatment is this difficult balance of pain control versus the risk of making things permanently worse.
Excellent. Now let's move back from the forefoot into the midfoot and hindfoot nexus. Section 3, arthritis and stability. We'll start with midfoot arthritis, the central stiffness.
Right. Midfoot arthritis. This is usually secondary to something else. Old trauma, maybe a missed Lisfranc injury, a flat foot deformity, Charcot.
And patients present with pain over the central arch, often with these bony bumps, these dorsal osteophytes you can feel.
And the management strategy here is heavily weighted towards being conservative. Orthotics, supportive shoes, analgesia.
The source material seems very down on surgery for this. Why is that?
Because the outcomes are just not good. The book specifically says that fusion or arthroplasty of the lateral 2 TMT joints has a universally poor outcome.
Universally poor. That's strong language.
It is. It tells the trainee that non-operative care is the absolute standard, and you should only really consider surgery if there's a major deformity that needs correcting.
Okay, that's a stark contrast to the ankle and hindfoot, where surgery is often definitive. This brings us to ankle arthritis. Fusion versus replacement, the great debate.
This is one of the biggest discussions in foot and ankle surgery today. Arthrodesis versus total ankle replacement, or TAR.
Let's start with fusion. Arthrodesis, the reliable standard.
It has the track record. Decades of data, predictable outcomes. Over 90% of patients get a stable, pain-free ankle, and modern arthroscopic techniques have made it even better. Faster recovery, fewer complications.
But the big question everyone has is, if you fuse the ankle, how can you walk normally?
It's the biomechanical loophole. The adjacent joints, the subtalar, and the triple complex, they compensate. They develop an increased range of motion to make up for the fused ankle.
So the stability from fusion comes at a long-term cost.
Exactly. You're putting extra stress on those other joints, and over many years, that can lead to secondary arthritis in them. It's the known trade-off.
Which brings us to total ankle replacement. The appeal is obviously preserving motion.
Right. And the technology is getting better. Custom CT-planned implants are becoming mainstream to improve accuracy. But it's a really challenging joint to replace. The forces are huge over a very small contact area.
And the survival data is the main issue, according to the source.
It is. It's the Achilles heel of TAR. A hip or knee replacement can last 20-plus years. Ankle replacements have a much higher annual failure rate, averaging around 3% per year.
So after 10 years, that's a significant failure rate.
It is. And the source highlights the problems with the UK TARVA trial, where some of the leading implants at the time had to be withdrawn. It just shows how tough the engineering challenge is.
So it's a choice between predictable stability with a known long-term cost versus preserved mobility with a higher revision risk.
That's the debate in a nutshell. And it gets even more complicated when you have arthritis in both the ankle and the hindfoot.
Right. Hindfoot arthritis and the triple complex.
Fusion, a triple arthrodesis, is the standard here if conservative measures fail. But what if both the ankle and the triple complex are shot?
You can treat them together, or one after the other, but the book has a pretty stark warning about doing it sequentially.
It's a landmine. The source states that the non-union rate of an ankle fusion after a subtalar fusion, or vice versa, can be up to 75%.
75%. That's astonishingly high. Why?
The thinking is that the first surgery disrupts the local blood supply and changes the mechanics so much that it just creates a terrible environment for the second fusion to heal.
So what does that mean for the surgeon?
It means that if a patient already has a successful subtalar fusion and then develops ankle arthritis, many surgeons would actually advise a total ankle replacement instead of an ankle fusion, just to avoid that massive non-union risk.
That's a fascinating clinical decision point.
It is. And for the smoking constricts the blood vessels. Diabetes causes microvascular disease. Both starve the bone of the blood supply it needs to heal and fuse. The risk of failure is alarmingly high, and you have to be brutally honest about that during consent.
Okay, time for a check-in. Pause and reflect. Imagine you are consenting a 55-year-old diabetic patient who smokes 2 packs a day and needs a fusion for midfoot arthritis. Based on the source material, what specific, non-negotiable complication point must be emphasized during the consent conversation? Answer: the massive increased risk of non-union, meaning the bones may not heal together, necessitating further complex surgery.
And our key takeaways, S3, are: midfoot surgery has poor outcomes, so stick with conservative care. Fusion is the reliable standard for the hindfoot. TAR is promising, but has a high revision risk. And smoking and diabetes are huge red flags that severely compromise fusion success.
Right. Let's shift from the bones to the ropes and pulleys. Section 4, soft tissue and stability challenges, starting with the big one, acquired flat foot.
The arch collapse. Now, some flat foot is normal, but pathological causes are common. And the most frequent culprit is the failure of the main dynamic support for the arch, tibialis posterior tendon dysfunction, or TPTD.
So the main support beam fails. Who does this usually happen to?
The classic patient is a middle-aged, often overweight woman, maybe after starting some unaccustomed exercise. The tendon degenerates, it stretches, and it loses its ability to support the arch.
And the arch falls flat, the heel rolls out into valgus.
That's the progression, and there's a definitive clinical test for this, a perfect memory anchor.
The single-leg tiptoe test.
That's it. You ask the patient to stand on just the affected foot and go up on their tiptoes. If they cannot do a single-leg heel rise, or if their heel fails to invert as they try, that confirms a significant advanced stage of TPTD.
And surgical treatment for that is a big deal.
It's a major reconstruction. It usually involves three things: a medial displacement calcaneal osteotomy to shift the heel bone back into alignment, a tendon transfer, usually the FDL, to replace the failed tibialis posterior, and a spring ligament repair to tighten up the static supports.
Moving on to ankle instability, most sprains get better with physio.
They do, but if the instability persists, you'll find a marked anterior drawer sign. If conservative treatment fails, surgery is an option.
And the favored technique is the Brostrom procedure.
Yes, an anatomical repair of the ligaments, and these days it's often augmented with a high-strength suture tape and internal brace to allow for faster mobilization. Using the peroneal tendon for reconstructions is now pretty much obsolete.
Okay, but if the pain persists after an injury and it's not really instability?
Then you have to think about an osteochondral lesion of the talus, an OCD, a cartilage and bone injury on the top of the talus. You'll need an MRI or CT to see it properly.
And the treatment is challenging.
It is. The book makes the point that true cartilage repair is still elusive. The mainstays are still just debridement and microfracture to try and stimulate some healing.
Okay, let's talk about tendon disorders, the fraying ropes. The most dramatic is the ruptured Achilles tendon.
The classic weekend warrior injury: 40 or 50-year-old, starts a vigorous sport, feels a sudden kick to the back of the calf.
And the source has an alarming statistic here.
It does. 1/4 of these are missed in primary care.
A quarter, that's huge. What's the mandatory test to avoid that?
The Simmons test. The calf squeeze test. You squeeze the calf, the foot should plantar flex. If it doesn't, the tendon is ruptured. The key is it's not reliable after about a week because of swelling and clot.
And the management is trending away from surgery, right?
More and more, yes. Management is frequently non-operative now, provided an ultrasound shows that the tendon ends come together when the foot is pointed down. Surgery doesn't seem to offer much advantage in function or re-rupture risk, but it definitely increases complications like infection.
What about chronic Achilles pain? Tendinosis?
For non-insertional tendinosis, higher up the tendon, it's non-operative. Eccentric exercises, shockwave therapy, and the critical point: steroid injections are strongly discouraged anywhere near the Achilles.
Because of the rupture risk.
The huge rupture risk. Now, for insertional tendinosis right at the heel, that's often associated with a Haglund's deformity or bony spurs inside the tendon. And the author notes that if you have significant bony spurs in the tendon, they rarely get better without surgery to remove them.
A difficult surgery, though.
Very high complication rate, a last resort.
Okay, let's pause for our final check-in on soft tissues. Pause and reflect. We covered two key clinical examination points. Why is the single-leg tiptoe test so essential for diagnosing acquired flat foot, and what crucial piece of information should you confirm before ever considering injecting steroids around the Achilles tendon? Answer: to confirm TPTD failure, and to confirm that you are not injecting into the Achilles itself due to rupture risk.
The key takeaways, S4, summarize this section. TPTD is the most common cause of acquired flat foot in adults, diagnosed by the tiptoe test failure. Achilles ruptures are increasingly managed non-operatively but require the Simmons test for acute diagnosis, and steroid injections are strongly contraindicated near the Achilles due to high rupture risk.
Fantastic. That brings us to our final section, Section 5, the systemic action neurology, tumors, and infection, the red flags.
This is where a foot problem isn't just a foot problem, it's a sign of something bigger.
We start with pes cavus, the high arch. And the source immediately flags unilateral pes cavus as a major red flag.
This is a critical point for any trainee. If a patient comes in with a high arch on one foot only, you have to think it's an upper motor neuron lesion or a spinal cord lesion until proven otherwise.
So it's a red flag for the spine.
A massive one. It requires an immediate neurological exam and urgent spinal imaging to rule out a tumor or something like a split spinal cord.
And if it's bilateral, both feet.
Then it's usually a generalized neurological condition, and the most common cause by far is Charcot-Marie tooth disease, CMT.
Which presents with that classic stork leg muscle wasting.
Exactly. And the source corrects an old belief here. The deforming force in CMT isn't overactive peroneal muscles. It's the relative preservation of the tibialis posterior tendon, which pulls the foot into that high arch, turned-in cavavarus posture.
So surgery is about rebalancing.
It's all about rebalancing, transferring that tibialis posterior tendon, doing osteotomies, all to get a foot that can sit flat on the ground.
Okay, let's talk about lumps and bumps. Tumors and lumps.
Common benign things are ganglia, giant cell tumors. But the most common comor is something called a plantar fibroma, or Lederhose's disease.
That painful lump in the sole of the foot.
It's linked to Dupuytren's in the hand and Peyronie's disease. And the crucial take-home message from the source is that surgery should generally be avoided.
Right.
High recurrence rate. And you often leave the patient with painful scarring on the sole of their foot, which can be worse than the original problem.
And the general rule for any lump.
Any large, rapidly growing lump, or one with night pain, needs a formal tumor workup. No messing around.
Which brings us to the most urgent clinical scenario, the diabetic foot crisis.
The silent destroyer. It's the perfect storm of peripheral neuropathy, so they can't feel injuries, microvascular changes, so they can't heal, and impaired immunity, so infections run rampant.
And the urgency anchor here is that these are all emergencies.
Absolute emergencies. A diabetic foot ulcer, septic arthritis, and especially Charcot neuroarthropathy all mandate urgent admission and management by a multidisciplinary team. Almost every major amputation is preceded by an ulcer.
Let's focus on Charcot neuroarthropathy, the hot, swollen enigma.
This is neuropathic joint destruction. The bones just crumble. And while it's often called painless, the source clarifies that most patients do feel some pain.
And it's so often misdiagnosed.
As cellulitis, gout, a fracture.
Yeah.
Because it presents as this hot, red, massively swollen foot. The key is to check the temperature difference against the other foot. It can be huge.
And immediate management is all about offloading.
Completely. A total contact cast or a CRO walker. And you have to be patient. The whole process, from the acute destructive phase to bone consolidation, can take 18 months.
18 months, wow. And what about surgery?
The trend is shifting. If a big bony prominence is forming that's going to ulcerate, there's a move toward early, aggressive reconstructive surgery to prevent that ulceration and subsequent amputation. It's high-risk surgery, but it can be limb-saving.
And finally, a brief mention of the most common complaint, heel pain.
Plantar fasciitis. Pain under the heel, worst first thing in the morning. It's self-limiting. Most cases get better within 18 months. For stubborn cases, it's ultrasound-guided injections or shockwave therapy.
Okay, let's run our final check-in for these critical systemic issues. Pause and reflect. If you see a patient with pes cavus, a high arch, what is the difference in urgency and workup if that arch is bilateral versus unilateral? Specifically, why must you order urgent spinal imaging for a patient presenting with pes cavus that is only on one foot? Answer. Unilateral presentation suggests an upper motor neuron lesion or space-occupying spinal cord tumor, requiring immediate neurosurgical assessment.
Great. And the key takeaways, S5, synthesize the most urgent points. Unilateral pes cavus demands an urgent neuro workup. Lederhose's disease should be left alone if possible. And any major diabetic foot complication, ulcer, infection, Charcot, is a surgical emergency requiring immediate multidisciplinary care.
We've covered so much ground from Chapter 41. It really comes down to a few core themes, doesn't it?
It does. The anatomy demands you understand those key concepts. The nonlinear ankle movement, the TMT keystone, the physics of the windlass mechanism.
And in the forefoot, it's all about managing load transfer. Hallux valgus shifting load to MTP2.
While hallux rigidus needs that movement restricted. And in the hindfoot, it's that constant balance between a reliable fusion and a riskier replacement.
But I think the most important lesson from this chapter is recognizing those systemic red flags. Diabetes, neurology. They change the game completely. They demand emergency protocols.
And that brings us back to that idea of compromise in surgery. We talked a lot about how ankle fusion works because the other joints compensate.
We did. And that brings us to our final provocative thought for you to mull over. If that increased mobility in the subtalar and triple complex after an ankle fusion inevitably leads to secondary arthritis in those joints down the line, as the source suggests it might, does that mean that ankle fusion, for all its reliability, is simply deferring the need for a future, much more complex and disabling triple or pantalar fusion decades later? Are we just kicking the can down the road?
That's a great question to end on. So take this framework, grab Chapter 41, and use the diagrams and the full text to really solidify these concepts. We hope this has helped you turn the pages into practice.
Thanks for diving deep with us. We'll see you next time.